This scan over here, this is actually a sagittal scan. It gives us the shape of the cornea, okay? It's basically an axial scan. So I don't think I have to explain too much with all the optometrists with what a scan looks like, what is ellipsoid, what is spherical, what is aspherical. So I think the first thing I'm looking at is the shape of the cornea. So on looking at the scan over there, the first thing I'm looking at is a number 8 pattern on the right hand side on the top. Okay, that is a normal pattern that we want. So there are other normal patterns also, which we will discuss. And then a little bit on the color, like, the steeper it is more on the redder side. The flatter it is more on the bluer side. Okay, after looking at the gross thing over there, then I try and look at the few things that are circled over here. Let me just magnify this a little bit. What are you seeing over here, this dot over here? The HVID is the horizontal visible iris diameter, is about 12.6. I want to see how big the cornea is, okay? When we compare the Caucasians, like the white people, and we Nepalese, our corneas are quite small compared to the white people. So basically, if the white to white is smaller, you tend to get steeper corneas. That doesn't mean it is keratoconus or something, When you're talking about steepness, you're talking about the keratometric values of the cornea. Okay? And then the second circle I would see there's an R value. See, R value is an offset over here. It's an offset trying to tell us the vertex of the cornea from the center of the pupil. That's basically an angle kappa. Okay, where are you looking? So where is your cornea located when you're taking the scan? And there's so many other things, but right now, just grossly when you're looking at it, just grossly, you don't want to go into the numbers details. You want to look at the keratometric value K1 and K2. This is at 3 millimeters. And then you go more below you go. This is at 6 millimeters and then 7 millimeters, 5 millimeters and 7. So these are your keratometric values. So the keratometric values will grossly give you your K readings. So the numbers that I would be really looking at is number 47. Okay, your keratometric value 47, in and around that. So everything lies above that would be suspicious, below that is normal, something like that. Okay, just consider 47 as your number. And then you look at the difference between the two K readings, K1 and K2. This is 41 and 45. That gives us a big idea already that there's a big keratometric, there's a big corneal astigmatism there, 41 and 45. Okay? That's almost 3.75 diopters astigmatism at 4 degrees. It's minus cylinder. Can you still hear me, Kapil?
Yes.
Okay. Then you want to also see a couple of things. Is your coverage, how much of cornea that you've covered. Okay. And you want to see the quality of your scan, whether it is centered properly on the visual axis and whether the quality of the scan is normal or not. So we want to see the quality of the scan is normal. You've looked into the keratometric values, you've seen it's a big cornea, and there's quite a big corneal offset. That's 0.4 millimeters. That's quite a big offset. That means it's got a large angle kappa. Okay? But looking at the shape of the cornea is a nice number 8. So at the beginning, the first thing I would see is the shape of the cornea. So what are the different shapes? Let's go. In the first row, you will see certain shapes. The first one is it's a round shape. The second one is an oval one. The third is a superior steepening. Fourth is an inferior steepening. Fifth is an irregular scan. The sixth one is called a symmetrical bow. The scan that we just saw was a symmetrical bow. The seventh scan is a skew. Skew is when the two circles are angulated to one another. Number 8 is an asymmetric bow. Number 9 is again an asymmetric bow. Number 10 is asymmetric bow with a skew. And below that, you have number 11, that is butterfly, lobster claw, a junctional or a vertical D. Okay, the last row is, they are the abnormal scans. Now these are basically the shape of your scans, okay? But then you have to say whether this is steepening or not steepening, or what is it, is steep or flat, or what is different. Now you want to really see is, see, these are the normal scans. A round scan in the center, an oval scan, and a symmetrical bow. These are normal scans, okay? But we're just looking at the shape of a scan. We're not talking about the steepness. So normally round, oval, and a symmetrical bow, these are normal shapes. Then what we're going into is asymmetric shapes, all right? The first one is a superior steepening. We'll explain what steepening is. Then you have an asymmetrical bow with a superior steepening. Then you have inferior steepening, asymmetric bow with inferior steepening. So this is a 6 image. So what I basically have over here is the same patient scan on the right hand side over here. What I can show you, I've circled 2 numericals over here, okay? I need to see those. And then I've put in so many things over here. I've put in the epithelial map, the posterior elevations, the corneal thickness, posterior corneal elevations. Slowly we'll come to all that. So right now we'll be focusing only on this scan. So when I look at this, when you look at this, is a very, very number 8 kind of it's a symmetrical bow kind of thing. But where you want to read your numericals is, this black line over here is about 3 millimeters. And this is about 6 millimeters. The numericals between the 3 and 5 over here at around 5, you want to read these values in the superior and the inferior over here. Just a second. So when you look at, can you see the numbers there? Kapil, can you still hear me?
Yes, sir. Yeah.
Okay, see the numbers over there is 44.8 inferiorly and 45.5. So the difference is hardly a 0.5 diopter difference. So we can't call it a steepening, you know, this is just a symmetrical bow. If you want some to be steep or flat cornea, I usually like to take 1.5 and 2 diopters of differences. So in a normal cornea, about 2 diopters of difference, I would say is significant. But if the keratometric value is about 47 or more, about 1.5, I would be worried, okay? So I'm looking at the difference in the superior and the inferior rings over here. So the other types of scan over here, the first one you can see is a symmetrical bow, but you can see the top circle is bent towards the right. If the angle, the vertical angle and the bent axis, you need the meridian, the degree is more than 22 degrees, then it becomes a little suspicious. It's called a skew. So the first scan is a symmetrical bow with a skew. And the second scan is an asymmetrical bow with a skew. The angle is about 22 degrees. This is something we don't like. A skew is something we don't like. All right. The other special shapes over here, this is a butterfly, lobster claw, and a vertical D. These are usually in ectasias and scarred and irregular corneas. Especially, the more commons that we see are the butterfly and the crab claw, also called as the lobster claw. And you can see it in pellucid marginal degeneration. So this is the very, very irregular type. You can see it in late keratoconus, or could be a scar, previous surgery, or a pterygium. That's not giving you a very proper corneal topography. It's an irregular topograph. Now, when you're looking at the risks over here, again, which are the risky corneas? And what are we talking about when you're talking about risky corneas? Is like we're talking about keratoconus. If the patient has keratoconus, or the patient has subclinical keratoconus, which is also called as form thrust. These are the high-risk ones. So you have an asymmetrical bow and a symmetrical bow with a skew. These are the high-risk ones. And then again, the butterfly, crab claw, and the vertical D are again the high-risk ones. Okay. But when you look at the normal shapes of the cornea, like when you see the topograph is round, oval, or symmetrical bow, but they have their keratometric values more than 50 diopters, then this becomes high risk again. Okay, so just looking at the shape is not enough. You got to look at the keratometric values also. The Kmax, 50 diopters, but a very regular shape, scary. Then again, when you're looking at a moderate risk, you have inferior steepening. Inferior steepening is when the top circle is missing and you have only a circle below. Or you have an asymmetrical bow with a superior inferior dioptric difference in about 5 millimeters. Circle is about 1.5 diopters, and the keratometric value is less than 47. Even though the keratometric value is low, less than 47, but you have these two types of shapes, becomes a moderate risk. And then if you have normal shapes and the keratometric value is 47 to 50, they also become moderate risk. For me as a refractive surgeon, taking risk is not a point. I take 0% risk. Okay, so moderate risk and high risk are out of any context that I would touch them. But then once I don't do surgery, I also have to give them contact lenses, or probably I practice orthokeratology or something like that, a hard lens, an RGP lens. Can you still hear me, Kapil?
Yes, sir.
Yes, sir. Audible.
Oh.
Yes, sir.
So when you get any of these risk factors, like a high risk factor or a moderate risk factor in a cornea, the first thing we want to rule out is, has it been warpaged? Okay, a contact lens can warpage your cornea. It's like changing the shape of your cornea. by using a contact lens for a very long time. So it can warpage your cornea. So you got to exclude contact lens wear. And you got to also exclude misalignment. Okay, sometimes when you're doing your scan, you're taking the scan of your left eye on a right eye dominant eye. Sometimes the right eye is looking somewhere else, and then you get a very misaligned topograph, which can give us a false positive or a false negative effect. You also got to rule out large angle kappas. So angle kappa is the axis from the center of the pupil to the visual axis. That's the angle kappa. Okay. You got to exclude dry eyes. You got to exclude corneal scars and other pathologies, and also exclude surgeries. Exclude anything. You got to take a good history. So when we look into the risk, a moderate risk can become a high risk later. A high risk can become full-fledged keratoconus, or a keratoconus can progress and might need cross-linking, or might need an RGP contact lens. So it's very, very important that we keep these data very, very valuable and save them. So whether it's progressing or whether they're contact lens wearers, and you might need it for orthokeratology or scleral contact lenses. So these scans can also tell you, give you the regular space in a scleral contact lens between the cornea and the contact lens. You can use it for everything. So more than me as a surgeon, I think you all are very, very important in analyzing the visual. The optometrist, the real backbone to analyze the vision, the quality of vision, why the vision is not good even after a full correction, the optical aberration, everything. So you all are very important. So you got to understand this very properly, all right? And I'm sure most of you all know a lot. So now, looking at the shape and looking at the keratometric values, now you should start understanding another thing that is called the elevation map and a corneal thickness map. So when you want to see whether the cornea is strong, we've looked into the shape of the cornea, we've looked into the keratometric values, we've learned how to correlate them a little bit, and now you want to look into the elevation maps and the corneal thickness map, okay? So let's go start with the corneal thickness. You know, thin corneas are scary. Everybody knows that, right? And thick corneas, you're all happy with thick corneas, but not necessarily that a thick cornea is strong, and not necessarily that a thin cornea is weak. Okay, let me give an example again. Bruce Lee, he was very, very thin, but he was very strong. But you can have a fat diabetic person who is very weak also. So a fat cornea does not mean it is a strong cornea. So basically, you start correlating the thickness with the elevations and the shape and the keratometric values. So let's go into the pachymetric value here. Can you see this is a corneal pachymeter from the OCT. Can you still hear me?
Yes, sir. Yes, sir. Yes.
Okay. So the reason why the MS-39 is very accurate is because it's using an OCT. The scan fluid images are not very, very accurate. So every time you do a scan fluid image, your pachymetric value will change. Okay? But the best, because the reason is there's a lot of scattering of light. You know, light is there. You blink, your tear level is thick, your tear level is thin. It'll scatter your light. With every blink, it'll scatter your light. Okay? So an OCT is very, very accurate. More than the OCT is your ultrasound, which is very accurate. But to measure the real good corneal thickness, you got to be on the thinnest point, sometimes which you might miss. Sometimes if you're touching the center of the cornea, might be thicker than the thinnest point, which is somewhere else. Okay? So if you look at the OCT map over here, This is a pachymetry. So you see the thinnest point over here. Can you see the thinnest point? Kapil?
Yes, sir.
Yes,
Yes,
sir. Yes,
sir.
sir.
You see that dot? Okay, that's the thinnest point. And this is the center of the cornea, all right? And this is the thinnest spot. And this is the other eye. So what we are looking at is basically how thin the cornea is. You got to go into the readings over here. So what we are trying to see over here, the first arrow over here, is SN and ST difference. So SN and ST means superior nasal and an inferior temporal. The difference between the superior nasal and inferior temporal thickness, you see in keratoconus, it's usually the thinning starts at the inferior temporal area. So if the difference is more than 42, then it's very, very significant. Okay? More than 42, very significant. Then he's telling you the pachymetry is about 486 in the right eye and 485 in the left eye. It is a thin cornea, but when you look at the difference between the two corneal thicknesses, they're very, very symmetrical. This is what is very important. If the corneas are very symmetrical, then you really don't doubt it, like, you know. But if there's a difference of more than 15 microns, if there's a difference of more than 15 microns, then you have to be really suspicious. There's something going on the thinner eye. So the superior temporal and the superior nasal and an inferior temporal difference of more than 40, 42, or a pachymetric difference of more than 15 microns, very significant. And you also want to look over here is the y-axis, okay? You know that this is the x-axis and this is the y-axis. So when you look at the thinnest point on the y-axis, you're looking at 200 and 442, all right, in the right and the left. We're talking about this point, where this point is. In the y-axis, if it starts drooping down more than 500, I start getting suspicious. And if it is about 1,000, well, 1 millimeter down, I would say, okay, does not touch the cornea. There's something definitely going on, okay? So when you're looking at the pachymetry, you're looking at the superior nasal, inferior temporal difference, the difference between the two eye thickness and how low, how below it has gone, the thinnest point, how below it has gone in the y-axis. And then most important now, again, in the corneal pachymetry is the epithelium now, okay? Can you still hear me?
Yes, sir.
Okay. So this is the epithelial map on a right eye, okay? The thinner the epithelium gets, the bluer it'll get, and the thicker the epithelium gets, the redder, the orangier, redder it'll get. So first thing you want to see is the pattern of the epithelium. The pattern, the normal pattern of the epithelium is, it is thin on top and thick below. That's the normal pattern. If the pattern changes, the epithelium gives you a lot of things. The epithelium, it covers up a lot of things. It also tells you a lot of things. So the thinnest point of the epithelium is here, okay? And you see, this is the thick epithelium, and this is the thin epithelium. So this is a very normal pattern. You want thin epithelium, thick epithelium, okay? And the second thing is, you don't want the thinnest point of the epithelium to coincide with the thinnest point of the corneal thickness. Like, you know, if you looked at the previous scan, you saw that the thinnest point of the corneal thickness, was somewhere here. So you don't want this point coinciding with this point, or even coming very close to it. Okay? So if you look at the other eye, the same thing is thin, thick, and the thinnest point is on top and superior, near the limbus. So this is a very normal pattern. And usually, when you look at that, around 50 microns is a normal thickness. That's the thinnest epithelium, is around 50 microns. And again, we don't want too much difference between the two eyes. Okay? So what you need to understand, if the pattern has changed, if you have thin epithelium below and thick on top, definitely there's something going on. If the thinnest epithelium coincides with the thinnest point of the cornea, or even coincides with the steepest point of the cornea, then you get worried. Okay? So before we go to the elevation map, all right? So this is a cornea. This is an ectasia reading scan, okay? It analyzes the keratoconus. So keratoconus analysis is by this scan. They use a lot of things now over here. They use what is called as a Bellin-Ambrosio data that takes in two types of data. One is the best fit spheres to see the elevations. It takes the keratometric values. And you have Holaday also, which also takes in, this takes in Holaday as well as Bellin. So it also takes in the ellipsoid, the toric ellipsoid value also, which is called as the float in pentacam and other things. So what he's trying to tell you now, let's go through it once again. So what I'm trying to see over here is the first scan over here is this is a posterior elevation. This is a posterior elevation with a normal value. This is a tangential scan. And then this is with the, you compare with the normal, this is the thickness value. This is a very important circle over here. The last scan over here, you see the circle over here? This is called a notable point. It's called a notable point circle. So the most important notable points are the thin point of your cornea, the thinnest epithelium, the steepest point of your cornea, the front and the back elevation, the offset, and all your higher order aberrations, everything it takes and plots it into these points over here. So everything, if this circle becomes smaller and smaller and smaller, if this circle becomes small, then you know most of these points are coinciding to each other, like they're very close to each other. The closer they are to each other, the more risky it becomes. So what you have to understand is this circle is very important. More than reading most of the scans, you've got to read this scan. Small circle, dangerous. Large circle, okay, good. All right. And then you have some of the numericals this side, okay, which are very, very small. And I've put them in another slide. Sorry, did you say something?
I guess there is a noise from the background, so I'll be muting. So please proceed with the presentation. I'll be check the honor.
Sorry, I didn't get you. I can't hear you properly. Kapil.
Yes, sir. Please proceed with the presentation. I guess there is some of from the audience, they unmute themselves, so I will be muted them. Please proceed with the presentation, sir.
Okay. Okay. So now you see that was the side numerical. Now this, the number one arrow is talking about a curvature asymmetry, okay? Now this curvature or symmetry, it is talking about the asymmetry of the anterior and the posterior cornea. Now what symmetry are you talking about? It's talking about asymmetry in the thickness, asymmetry in the curvatures. Like sometimes it's also talking about asymmetry, the ratio at which the cornea is becoming thick in the periphery and thin in the center. So basically it's a symmetrical, asymmetry in the cornea in the same eye. It's analyzing a normal cornea and analyzing the patient's cornea, and then it's comparing, like, the ratio at which it is becoming steep. Like we know that the cornea is prolate, is steep in the center and flat in the periphery. So a prolate cornea, it should be so much steep in the center and not more than that compared to the periphery. Or it should, this is what it's comparing at. The curvatures in the same eye. It's basically taking a tangential curvature. The tangential reading, not the sagittal reading. These are very, very fine. And he's talking about the front and the back asymmetry. And if you look at these, you see these green lines. They're small graphs over here. And you have this green area, and you have the yellow area, and you have the red area. And you have these small indices. So if these indices, they become longer and longer and touch the yellow one, then it becomes quite dangerous. It's telling us that something is going on. And if it crosses that, it's definitely dangerous. And then again in the back elevation, you see there's hardly any indus in the back. Okay, so the color coding over here, green is normal, yellow is a little risky, and red is scary. You see the arrow 2 over here, BCV. Now again over here, it's using two things over here. That it uses two things. One is the best fit sphere. I hope everybody understands best fit sphere. So best fit sphere is a principle of the Bellin and Ambrosio. Whereas Holliday and everybody else, Holliday uses the toric ellipsoid, the float and everything. So we are using the best fit sphere, and all your higher order aberrations are calculated and put into this. So it's measuring your curvature, your elevation with your comparison with your best fit sphere. So a best fit sphere, again, I hope everybody understands, is a sphere which is considered normal. And then it compares your steepening and flattening with that in the front as well as the back. And it also is putting in all the higher order aberrations in the front and the back with a root mean square value, okay? Usually over here, you're supposed to get an arrow if it's something suspicious, but nothing is here. It's green, yellow, and red. And over here, at the end over here, is showing you the corneal thickness. This is showing you the corneal thickness, which is about 498 microns, which is still on the green side, which is telling you is normal. The R value, that's the angle kappa over here, and this, the offset at 331, and it is telling you it is normal, okay? So basically what it's telling you is the elevation map in the front and the back are normal. The higher order aberrations are within normal limits. The keratometric values are normal. The elevation maps, you're talking about the front and the back elevation, are normal, okay? And this is a normal cornea. So nowadays, since you're putting the OCT, the epithelium, the keratometrics, the higher order aberration, and you don't have to rack your brains too much. Say 10 years from now, we had to use 3 scanners just to get, and you had to really rack your brain, whether it's a normal scan or whether it's not a normal scan. Nowadays, it's so easy, like, you don't even have to rack your brain. The software will just tell you it's a normal scan, these are the values, okay? But this is artificial intelligence. There are certain times the artificial intelligence is not adequate. And I'm sure optometrists like you're a few steps ahead of surgeons like us in understanding what is a scissor reflex, why there's a big astigmatism, why the visual acuity, why the contrast, all that. So I think we also have to use our brains, and artificial intelligence is very, very important, but the clinical side we should not forget. Now this is again a scan of a person who is keratoconic. So grossly, let me show you. I'm looking at the corneal shape now. First thing, I look at the shape of the cornea. It's like, this is an irregular shape. I mean, this is inferior steepening a lot. There's a big back elevation. Very significant. You can see this red over here. This is a significant front elevation and a significant back elevation. And you look at this circle over here, it's so small. Did you realize that? See, the circle is so small compared to the cast. Okay? Can you still hear me?
Yes, sir.
Okay. Now, when you're talking about elevations, what are the normal elevations? Okay? Let's go to that. Where have I written? Okay. So now looking at, this is a keratoconic eye. Like looking at it, you can tell. These are the values. Let me put this here. It's telling you, see the indices, it has crossed the yellow and gone to the red. And you have an arrow here, is a red triangle saying, be careful, something is going on. The front elevation, I mean the front and the back asymmetry, curvatures. And then the BCV, you see all the indices have crossed the yellow line and is in the red. And this arrow also tells us if the things are suspicious or like, moderately suspicious or very suspicious, it goes into the red area. And it also tells you the corneal thickness, which is moderately thin, not very thin. And the R value, the apex of the cornea, is like way far off from the center of the pupil, 1.2. So even 0.25 is significant, and it also tells you the axis. So when you're talking about the elevations, a front elevation, when you compare it, this patient has a front elevation of 23 and a back elevation of 53. So what is a normal front elevation in comparison is 8. Okay? And a back elevation more than 16 is significant. So front elevation more than 8. You see this? Normally front elevation more than 8 and back elevation more than 16 is very significant. If you look at this patient, it's 23 and 53. Very, very, this is keratoconus definitely, all right? But in the hyperopic patient, the back elevation is about 10 more. So it should be around 26. So more than 26 would be normal. In myopic, 16. Hyperopic, 28. Okay? So over here, what you're K, the AKF and the A is, these are your values in the front and the back. And the KVF is your elevation, okay? It's 23 and 50. The front elevation and the back elevation. All right? Are you getting it so far? Kapil,
Yes, sir.
can you
Yes,
still
sir.
hear me? Okay. So now, there are other things So the other things now you want to see over there, you see this page has been divided into 3 sides. On the left hand side is what you have is a 6 millimeter area showing me what is called as the root mean square is the higher aberration in the front surface and higher aberration on the posterior surface, and divides it, and you have a root mean square area over here. And then this chart is a point spread function. So the higher the aberration is, the more is the light scatter. It tells you about scattering of light. Okay, just grossly you can tell this patient has a little bit of horizontal coma, and you can also simulate his visual acuity over here. This is what he has actually, and this is his graph. So if this graph is very close to the y-axis, the weaker the cornea is, the further it is, the stronger. Okay, something like that. And this is the Zernix polymers. What you want to see over here? Can you see this chart? Kapil, can you see this Zernix
Yes, sir.
clearly?
Yes, sir. Yeah.
Okay. Because I'm presbyopic, I can't see it. So I'm going to put it into another slide, okay?
Yes, sir. Okay.
So
No
this
problem.
is something you need to understand a little bit, not too much. Let's put it in another slide. So what I usually look, first thing I look is at number 3. Okay? This is your higher order aberrations after removing all the other stuff over here, whatever you have. Okay? So the higher order aberration, usually number 3 over here, for me a normal value is about 0.4, 0.5. 0.6 is not too bad. It's about 0.4, 0.5. That's our normal vision. I mean normal reading of it. This is what I want. So if this is high, so this patient is about 0.6, then I start wondering why this patient has a little bit of higher order aberration. Okay, the total aberration over here is 1.76. And then I want to find out what's happening. Why is the total aberration high? And you look at this astigmatism, it's the same patient. It's almost about 1.8 diopters of corneal astigmatism, it tells us. The low order aberration is minus 1.65. So you know what I'm trying to say. It takes out all the other aberrations and gives you only the high order aberration over this is 0.4, 0.5. More than that, I start becoming suspicious. Okay. And then when you're looking at the Zernix polymers, so what you need to understand, what I usually look at is so this one over here, this is vertical coma and this is spherical aberration. Horizontal coma. Okay, so I want to usually look at this. Okay, now you can look into all the numerical values below over here. Okay, you have asymmetry, foil, tetrafoil, all so many things. What I really want to see is the spherical aberration and the vertical coma. This is what you can look into everything. If you look at that, and you should read the numerical value below. So the numerical value below, it says the spherical aberration is about 0.4, which is quite significant, and the vertical coma is about 0.12. That's not too much, okay? So basically, he has a little bit of a high order aberration. That's probably because of his astigmatism. And the point spread function looks okay. Not too much of vertical coma. But if you go to a keratoconic patient, see, this is what you'll get. See, the same keratoconic patient, you see, aberration in the front and the back. You see the amount of light that is getting scattered. See this graph, which is almost flat on the y-axis and the visual simulation. And then you look at that. If you look at number 1, that is his vertical coma is 0.75. So all these numericals, it should be below 0.25. Some say 0.2, some say 0.25. I like to put it 0.25. So more than 0.25, I start getting worried. So all the numbers below, it should be below 0.25. So number 1, that is the vertical coma, is 0.75. That's quite high. Then number 2 is spherical aberration 1.0, so very high. And number 3, the higher order aberration at the end is about 3.37, which is very, very high. Okay, so this is the reason why a keratoconic patient, even after you give them a nice proper glass with a 6/6 vision, they always have some issues because of the higher order aberrations. The vision is not as good. They have so much of light scattering, which can be reduced by contact lenses. Okay, so far have you understood?
Sir, yes, sir.
Okay, I wouldn't be going more than this. Okay, so far I've got 67 slides over here. I think we'll stop at 30, right? So the real thing is looking at the shape of the cornea. I think you've understood the different shapes of the cornea. You've understood the steepness, the keratometric value, 47 is the number below that, or difference between the superior and inferior keratometric values, not more than 2 diopters at 3.54 millimeter circle ring. Your elevation map, your front elevation should be not more than 7/8. Your back elevation should not be more than 16 in myopic patients, and 26 to 27 more than 26, 27 in hypermetropic patients. Okay, and your contrast and your high order aberrations have to be very low to make this cornea like a strong cornea. So I'm going to stop over here. If I say too much, it's been 10 years and I'm still learning. Yeah, so 1 hour is not enough. So we'll try and grasp it. Like the more and more scans that you'll see, the more you'll understand. Okay, Kapil, can you hear me still?
Sir, yes, sir. Sorry.
Yes, sir. It's so clear. Yes.
Can you hear me clearly, or is just?
It's clear. It's clear, sir.
Yes, sir. Yes. Okay, sir. Actually, have to. Yes, sir. Actually, have to go for the discussion round, sir.
Yeah, if someone has a question, yes. But yeah, I try to explain a lot so that nobody asks me questions. Okay.
Okay. Okay. So, if anybody have a question, please.
You can just give me a text.
Okay.
Or you can also give me, my.
There is one question from the Gauri specialist, sir. Thank you so much, Gauri sir, for your question. Am I audible to you, sir?
Yes.
Okay, sir. There is a question from the Gauri sir. So he is asking for which type of aberration you really consider important for screening a patient undergoing the refractive surgery.
Sorry, I can't hear you properly. Which kind of? Can you write to me?
Yes, sir. Which type of aberration you really consider important for screening a patient undergoing the refractive surgery?
Vertical coma and spherical aberration.
Okay.
Vertical coma.
Okay, vertical coma is important. Okay, sir. So if anybody has the question, please just pop out, or you can unmute yourself and ask for the question. Sir.
Hi, Gauri. Gauri, are you in Nepal or are you in Australia?
Yes, sir.
Where is Gauri?
Hello, Dr. Saab. I'm in Australia.
How are you,
I'm on my
Gauri?
way back home. Yeah, because it's night now. It's already 7:40. So going back home.
Okay. All right, Gauri. So
But
good
I
to
was
hear your
listening
voice.
on my way. Yeah, I was listening
Yeah.
on my
Thank you
way
so
back.
much. Thank you for listening, Gauri.
It's really
Yeah.
a refreshing topic actually. I just recapitulate the things I did before. So
Yeah. Thank you for
thanks
listening,
for the
Gauri.
for the
Thank you so
session.
much.
Yeah, thank you so much, sir. Okay.
You're welcome.
Thank you, sir. Thank you, sir.
Yeah.
Sir, I have a
If
query.
anybody
Like,
has any
when
question or you want to write to me later,
yes, sir. We'll be posting you later as
anybody
well.
wants to
So,
write to me.
so I have one confusion regarding the optical aberration. So, basically, for the VKC case, we generally see in the adults. So, if the patient who is suffering from the VKC and uh, still they have a aberration and they are basically they have a basically high astigmatism. So if they want to go for the refractive surgery, if they want to go for the surgical procedure, so what the things that we should have to consider?
See, all the things that I said is very important. Yeah. So keratometric value, the shape, the elevation maps, and everything. Sometimes, keratoconus, they also are wrongly diagnosed as VKC. So they usually have subclinical keratoconus, and they keep rubbing their eyes with redness, congestion, because the quality of vision is not good, and these people keep rubbing their eyes. And sometimes it's very important to take all your scans because sometimes you have a subclinical keratoconus hiding there. So VKC is, I would be very worried about patients with VKC sometimes, because even after surgery, if they keep rubbing their eyes, and these people have a little bit of a rougher cornea, the tear levels, the smoothness is not very smooth, and this is why they have high order aberrations. Like, until and unless everything is not really normal, you don't go with refractive surgery. What we really need to do is put them on steroids and sometimes a lubrication for a long time when everything is normal. The tear level, the cornea is smooth, eye is quiet. Sometimes you get very good scans again. Even the high order aberrations, they come down. And then we can decide for surgery.
Okay.
Otherwise, no.
Okay. So there is other types of corneal topography as well. So why the ZEUS MS-39 is considered it's so important as compared to the other corneal topographers?
Okay, so you have serious. So you are in teaching hospital, right? No?
Yes, sir.
You're in teaching hospital, right? So the scanner that you're
Yes,
using
sir.
is called the Cirrus. Okay. So Cirrus, if you look
Yes.
at my first slide, if you really go to my first slide, okay, the first thing it says, it's a spectral domain OCT combined with a placido disc. Okay. Whereas a Cirrus
Yes, sir.
is a skem fluke and a placido disc. So an OCT is more superior to a skem fluke. बुझ्यो?
Okay. Yes, sir.
So you have तिमीहरुको त्यहाँनिर OCT छ नि जस्तै कि हेडलबर्ग OCT छ हैन रेटिनाको लागि.
Yes, yes, sir.
Yes, the OCT is more accurate than the skem fluke imaging. Okay.
Okay.
So it's combined an OCT with a placido disc. बुझ्यो?
Okay. Yes, sir. Yes.
So,
Sir,
I
yeah,
just
okay,
wanna
okay.
add. So, reporting हेर्दाखेरि त साइरस र यो MS-39 एन्ट्री सेगमेन्ट ओसीको to the reporting चाहिँ is it same or के छ सर त्यसको?
No, the software is the same. The Phoenix it is called. Okay. Is the software, the Phoenix software does the reporting, हैन? But taking the picture is more advanced and specific. Say will be your OCT. So if you have an opto view, teaching more opto view छ नि हैन अब
हजुर सर
Up to events? Yes, sir.
OCT.
the anterior segment OCT छ भने then you can combine the scan fluke and the OCT. दुईटा स्क्यानर छ हैन त अब बुझ्यो हैन
Yes, sir.
तिम्रो एपिथेलियल म्याप हेर्नु पर्यो कि टिचिङको सिरियसमा एपिथेलियल हैन and since it's a scan fluke your corneal pachymetry is not reliable. So I think you have to do every time you do an imaging your corneal pachymetry will be different. 490 or 500 or 470 480 त्यसो देखाउँछ क्या and it's not repeatable. Every time you do it you'll get a different value.
I have a question regarding the principle of this machine. Basically, these machines are work on the sim log principle, right, sir? Hello, sir. Are you there?
Basically के हो नि यो I'm here.
यसको principle
Basically the scan fluke भनेको चाहिँ हैन
So yes,
it takes
यसको
lots of
principle
photographs
चाहिँ
all the axes.
okay. Hello, sir. Are you there?
Yeah.
Yes, sir. Sir, this machine basically works on us. Yes, sir. I guess our net is so lagging.
So the scan fluke, if you look at a scan fluke image, हैन
Yes, sir.
it
Yes,
is
sir.
superior to a placido disc. Okay, पहिले placido
Yes,
disc
sir.
चलाउँथ्यो. So then the scan
Yes,
fluke
sir.
it gives you the elevation maps. Okay, and after
Yes.
that is then you have the OCT. Okay, which is even more. I mean, this is supposed to be more superior combination of placido disc हैन. So अब बिचमा चाहिँ scan fluke र placido disc combine आएको थियो. अब चाहिँ OCT र placido disc combination मा आयो. So it gives you more data, more of everything, more accurate elevation. Like OCT is more accurate reading. There's less light scattering. सबै थोक is more repeatable. It's more accurate. त्यस्तो हुन्छ क्या.
Okay, sir.
But the scanner that you have in teaching Austin is a very, very good scanner. Okay? It's an amazing scanner. It's not that I'm trying to tell you this is this and this. It's an amazing scanner. It's just that now you need two scanners, one OCT and one scan fluke. दुईटा चाहियो नि त. So the MS-39 is like, it's a combination of both. It's fast, it's easy to diagnose. घरिघरि यत्रो उति राखिरहनु पर्दैन पेशेन्टलाई. In one, you can do it in one scan itself.
Okay, sir. I guess it have also a mammography technique, right, sir?
Yes. So which we'll be doing it in some other topic. तिम्रो
Okay.
mammograph पनि हुन्छ त्यसमा.
Yes,
It tells you the amount of the meibomian glands that are destroyed.
Yes,
Okay, the
sir.
ducts that are destroyed, and do the quality of your tears, त्यहाँनिर. The percentage of destroyed meibomian glands and the percentage of your destroyed mucus gland, त्यो सबै देखाउँछ क्या त्यसले. Which is also there in the serious. Do you still have it? You have it in teaching also, right?
Yes, sir.
Yeah. So it has a pupillary graph. It gives you the size of your pupil, the scotopic, the mesophic pupil, and it also tells you the pupil how far it is from the corneal vertex. So the vertex of the cornea is supposed to be, not exactly, but supposed to be where the visual axis is. Okay. So it gives you an angle kappa roughly.
Yes, sir. Yes, sir. Okay, sir.
Okay.
Yes, sir. So can we do the count of the posterior cells like in what we usually see the polymegathism of the shells in the posterior desmosome layer?
You cannot see. No, you cannot see.
Yes, sir.
For that, you need an endothelial cell, the specular microscope. You cannot see.
Yes, sir. Okay. So I'd like to request, please, if anybody have a question regarding the corneal topography, or even we can answer some of the question, I guess, from the refractive surgery directly related with the corneal topography. So if anybody has the interest, please unmute yourself and can ask a question. So can we go once again for the procedure and management and all the mostly according with the refractive surgery on next class, sir?
You'll have to write to me. के अरे भनेको? The
सर
procedure.
यो हामी चाहिँ सर हजुर हामी यो रिफ्र्याक्टिभ सर्जरीको बारेमा चाहिँ टेक्निक यो प्रोसिडियरहरू अनि हाम्रो के कस्तो कस्तो क्राइटेरियाहरूलाई चाहिँ यू क्यान गो फर द सर्जरी म्यानेजमेन्टहरू यो बेसिकली मोर रिलेटेड विथ द सर्जरी एज अ पोइन्ट अफ भ्यूबाट चाहिँ हामी अगाडि बढ्न सक्छौँ एउटा प्रेजेन्टेसन पछि.
So we can do that later, eh?
Okay, sir. Okay, so we have almost completed all the.
तिमीहरुको जुन चाहिँ उ छ नि?
Yes, sir.
Classes के I'm getting missed out on that क्या?
Okay, sir.
Usually I have not been able to attend because you didn't send me those links. I would definitely like to join the Optum class. So, right?
Okay, sir. I'll be doing regularly. So, my submission was somewhere.
Link after the class has started.
Okay, sir. Okay. Thank you so much once again, sir, for the nice presentation. And I'd like to also thank all the attendees for your presence.
Me too.
And
I want to thank everybody for listening to me so quietly.
Yes, okay, sir. So I guess we are just in the session. So once again, thank you so much for your presence. And if you have any comments or feedback for us, please put on our groups or directly you can Gmail to us as well. So once again, thank you so much. Thank you so much, Kishore sir.
You're welcome, Kapil.
Have a good day, sir.
You too. Bye.
Okay, bye, sir.
Bye.
Hence, hereby I ending the session. Thank you so much.